Welcome to those of you who are joining. We're just going to give it one more minute to allow a few others to join the call, and then we'll get started. Great. Well, I suspect we'll have a few others join, but why don't we get started? Welcome, good morning, good afternoon, depending on where you are. Thanks for joining today's roundtable that's focusing on increasing utilization for worksite health centers. For those that you don't know me, this is David Kite, filling in for Larry Boris, who is on vacation. Good for Larry. I'm a NOAC board member and National Director for Alliance Employer Health Centers Practice nationally. And joining me today is an outstanding panel of thought leaders in the industry, and I will call on them to introduce themselves. Dr. Bussell, do you want to go first?
Sure. John Bussell, Chief Medical Operations Officer at Quad Med, been here for about 3 years. A family medicine physician by training, and spent some time in traditional health systems as a hospital CEO and also with Cigna in managed care.
Great. Thanks, John. Sarah?
Sure. Hey, everybody. Sarah Lord, EVP of Product for Crossover. I've worked here for about 12 years. I spent a lot of time in operations, overseeing our centers, launching our centers, continuously improving our workflows. About 5 years ago, I switched over to product. So now I oversee our technology teams, data science analytics, and member engagement.
Great. Welcome, Sarah. And Leah?
Yes, hello everyone. Leah Cathy, EVP of Operations for Premise Health. I've been with Premise Health in various operations roles for the last 8 years. I currently oversee all of our operations at our health centers, our client relationships, and then I also oversee our centralized operations. So that includes our implementations, member marketing team, member experience, and member engagement.
Awesome. Thank you. And Katie?
Hi, good morning or afternoon. Katie Vickers with Marathon Health. I lead our client success team. We partner with our strategic customers to understand how they would like to drive engagement and the outcomes that are important to them. And so excited to be here. I've been with Marathon for 9 years, and prior to joining Marathon, I spent 15 years with Anthem Blue Cross Blue Shield. Thanks, David.
Great, thanks. And just a little bit of housekeeping before we jump into it. I will be facilitating the discussion. We're not going to share any materials. This is a recorded session, and the recording will be available on the NAWAC website for members. We do hope this is an interactive discussion. Feel free to submit questions as we go. I'll be monitoring the chat. And then we'll try to leave a few minutes at the end for any questions, but you feel free to jump in or raise your hand. We'll try to field them as we go. And I do want to just thank everyone for joining. It should be an interesting conversation. Dr. Bussell, let me start the conversation with you. I think most stakeholders that are involved with governing a health center, whether it be on the employer side or the vendor side or the consulting side, everybody's focused on increasing utilization in general. But I think a lot of people struggle with exactly where to start. So if you were beginning a project with any particular health center and with a focus on increasing utilization, where would you recommend starting?
Thanks, Dave. A nice softball question to get us started here. I think we would all go back. We're looking at the data first, right? So we want to look at the data. We want to understand what the needs are of the population, what the potential barriers are of entry into our health centers. For us, we use Epic as our electronic health record. We have a ton of data in there for our current patients. We also have access to a module called Cosmos, which is where all of Epic customers are able to put in data. We can pull aggregated information from a geographic area and understand what specific needs meet that population that our health centers are located in. Obviously, looking at claims data and when we get eligibility files from our clients, looking at the geomapping and when we pull all that together, then we can have a strategic conversation with our clients and consultants and make sure that we're making the right decisions to pull all the levers that are necessary to increase that utilization.
That's great. Leah, same question. I would imagine data is fundamental to your answer as well, but any other kind of additional points or thoughts in terms of where you would start a project like this?
I absolutely agree with John on where to start. I would keep in mind that, we know that employers and unions pay for healthcare for more than half of the population. And so focusing on things like primary care first can make a huge impact in the employer's population. So agree, totally looking at the data and having an open discussion with those stakeholders, the employer, the health center partner, the consultant, understanding where we can make things more simple and easier for our population to navigate through healthcare. It's very complicated, and really start to develop, just even a couple of objectives that you can start with and then start to build on from there.
One of the topics that had come up in terms of increasing utilization was setting a target for what utilization should be. If we're thinking about it like that, what is the optimal level of utilization? Maybe I'll direct that question at Sarah.
Yeah, thank you. I think ultimately you want as much utilization as you can get. But I think starting with a conversation with the client and making sure we really understand value. What is their target? Even, touching a little bit on the last question about, how might you start? If a client's absolute goal in order to keep the program is 40%, then if you're at 5, you have the target, you have the actual, the problem to solve is between 5 and 40. That's going to look very different than if they're already at 75% utilization, they want to show incremental growth, you got to get 4 or 5%. Those types of things are going to look different. So I think sitting down with the client, really understanding, okay, what does success look like for this program? And then once you have that, you can start to get into the data and see, what are those options? So if you think optimal in terms of penetration, so number of unique users, I think we're always striving for as many unique users as we can get. And I would also encourage us to look at what we call balancing metrics. So utilization is one number, but if you want to see what is the success of the program, then you're going to want to look at how many people are using, how are they using? Are they using appropriately? Do you have 100 people that are getting 25 visits a year? Does that make sense clinically, right? Or do you have people that are underutilizing? Maybe they came in for that, preventative exam or the flu shot, but they're not returning. So I would say partnership, making sure you're driving value, and then looking at the actual users to see where you might need to pull some levers. Go get new people, get the people who are in to use so you can ultimately drive the outcomes that you want.
That was a nice layered answer to that question. Lots to unpack there. Katie, thinking about the utilization optimization question, and I guess using the data from the NAWAC survey, mature employers report approximately 50% utilization for employees. And obviously, there are many different types of employers that are responding to that question, many different types of populations that they serve, industries that they're in. How do you think about setting a target for optimal utilization, and because I think, you know, we need to set a target in order to attain it. But how do you
Right.
think about it?
Well, and I loved Sarah's answer around making sure it's the right set of users too, because a piece inside that 50% would be to look at how many of them are chronically ill, right? So one of the metrics we always try to track to is what percentage of those that are engaged have a chronic condition. And, you know, to Leah's point and John's point, we know driving primary care is a way to control those costs downstream that are driven by those with chronic conditions. So that would be another lens to kind of angle in on setting that target. The other metric that we tend to think about is the cost of care for those engaging versus non-engaging. And, you know, let's say 50% is achieved in that year one, there's a positive ROI. You know, the challenge with the client is, okay, what do we want to do in year 2, year 3, year 4? How do we want to increase those levels of engagement? Because then you have to design programming to get maybe someone that's never engaged in the door, or someone that's a high user of urgent care or ER to kind of transition their care to the health center. So every step along the way, you know, data is the king in terms of trying to determine what the right population is, how to get them engaged, and whether or not we're generating the right return for the client. The other piece around your initial question, David, on just like starting off, how do you drive utilization? The important piece that we always want to think about too is like a cultural assessment of the population, right? You know, what's their primary language? What's their job function type? How do they often receive communications? Have they engaged in this type of programming before? Because understanding the population, I think, is really important to putting together utilization targets and programming to help achieve those targets.
So I'm hearing, you know, data being a consistent theme in the responses so far, and that makes a lot of sense. And for those of you that have been in the industry for a long time, I think things have changed. Unlike 20 years ago, everybody's now, at least on a minimum, have an electronic medical record, and often other more sophisticated technology resources at their fingertips. But from the stakeholder perspective, you know, we're faced with now a mountain of data to sort through on both users and non-users, but not just data within the EMR, medical pharmacy claims, productivity, obviously some, depending on the situation, some alternative data points as well. How do you effectively leverage access to all that data? What data do you need to be, or where do you start kind of that process? Maybe I'll direct that question to Leah.
Yeah, where we start that process is it's amazing when we have the ability to leverage claims data and our clinical data, our EMR data. I think you know, as we have our, you know, data scientists and our analysts here at Premise that are able to really take that data, including the pharmacy data as well, and really begin to start to prioritize where care is needed the most. That is when we are able to focus on, you know, those folks that have multiple chronic conditions, that have high, you know, hospital utilization, high ER urgent care visits, and then really start to build a targeted engagement strategy to connect with those members and proactively offer support to those individuals and get them into a care plan, get them into the health center and get them into a care plan to really make an impact on their health care, which we've been able to see time and time again.
So I'm hearing, you know, targeting specific high value opportunities. Katie, when you're approaching a client and trying to, you have complete access to all these different data points. How do you prioritize that? How do you leverage the data to really, if you're looking for low-hanging fruit and to increase utilization?
Yeah, I think it comes back to there's two buckets, right? Those that have never used it and what could we do to get them in the door? And then those who either are the most costly on the plan or have, chronic conditions that the health center can tackle, right? So maybe we want to look at diabetics. Maybe we want to look at those that have um, mental health conditions if we have behavioral health, services on site. So you sort of rank order your claims, right? And I think everybody knows it's going to be a combination of musculoskeletal, mental health, and then, a series of chronic conditions after that, and start to put together either outreach. So, it might be kind of weird if I got an email that said, hey, you're overweight and need to exercise more, right? But if I got a phone call from the health center reminding me that it's time for my annual visit and, to get that scheduled, I might be more apt to take action. So, we tend to lean a lot into, email or electronic communications or home mailers or newsletters. But one of the most effective things that we have found is like a personal outreach from someone at the health center to either a previously engaged patient or someone that's never engaged. And it just makes like a really nice touch to remind the individual that, hey, we're here. It's a free or low cost service. These are all the things that we can do. And we typically have a high response rate to that type of outreach. And so, I'm thinking of a few campaigns that we've done recently, to diabetics who haven't been in within the past 12 to 18 months, trying to get them back in and take advantage of the services. And our care teams love doing that, right? They love being there in a way that's meaningful to the patient. And so they see this as an extension of their, hands-on clinical work to help get patients back in the door.
Yeah, I love that approach. One of the questions that comes to mind as I, hear that discussion was just the kind of enhanced capabilities we have to target and identify, opportunities for outreach and engagement. Leah, how do we balance access to that data with kind of cultural sensitivities, concerns of the employer, to where that kind of outreach is deemed disruptive or a breach of privacy?
Yeah, I think that is a really important question and topic amongst our employers and our members as well, their population. We've got to be able to communicate that that there is high security when it comes to the data. That the employers don't have access to that data that we're utilizing. From an outreach perspective, it really is multifaceted. When we're talking about doing that proactive outreach, it's really about an outreach to begin to let the patient or member know if they haven't utilized the health center, to let them know that, hey, we are calling on behalf of, either the employer or the health plan or the health center, to let them know that here are these services that are available. And it's really through some motivational behavioral interviewing to get that member or patient to start talking about what they are struggling with. And then that really starts to lead to further conversation for that care manager to start helping them with getting them into a visit and start creating that health plan or care plan journey with them. So it's not, we talk about it being a targeted approach, but really at the end of the day, it is about, it starts with more of a general outreach, and through that conversation is what they're having. it opens up the door for that member to also understand what their kind of motivational level is to want to make a change and want to do something about their health.
The one concern I hear relatively frequently is kind of questions around when it goes kind of tied back to the appropriate utilization and you know, not creating visits or engagement that's not going to drive value. But and maybe it's a question for you, Dr. Bussell, as we think about the different types of visits that we can drive activity around within a health center, whether it be biometric screenings or just different opportunities to engage with individuals. At what point are we crossing over into ineffective utilization? I don't want to classify it as induced demand because in general that's a good thing. But there's definitely certain types of visits that aren't really adding value in it from an ROI equation.
Yeah, I mean, and sometimes when we're looking at metrics and we're just looking at utilization, let's say we're defining utilization as how busy our providers are. So how many of their open scheduled visits are booked by a patient. If we're just looking at that, we're not really looking at what the outcome that we're trying to achieve is. So if we're just trying to fill them up with patients, we can do what the community providers do and see every patient every month, and we can meet those utilization targets. That's not high value. And so that's really not what we're trying to achieve. And so along with our clients, we want to understand what the goals are for the clinic overall. And ultimately, we want to drive utilization that's going to improve quality of care and reduce medical plan costs. I mean, I think that's really what we're all trying to achieve here is, improve quality of life for our employees, make sure they're as productive as possible and at work as much as possible, and then reducing costs on that medical plan. And so if we're going to get people into the clinics, we want to make sure that we are getting those high value, those higher cost people in maybe a little bit more often. And then making sure that we're getting the people who don't necessarily use health services as often as they should in for their annual exams and preventive and hit all those metrics. So, when I kind of look at participation versus utilization and, even PCP engagement, so provider, our primary care provider engagement, there's several different ways to look at how we're going to outreach and who we're going to market to when we're creating these campaigns. So we want our providers to be busy, but we want them to be busy doing the right work in the clinics. We want to see as many patients or as many of the membership that we can, as long as it's something that is defraying the cost from the outside community. So we don't want to just create unnecessary visits for the sake of being busy. We want to make sure that we're getting people engaged in our health center instead of going to the community. And then really for me, the highest value is that PCP engagement. If we can get them attached to a PCP, attached to a care team, then we can really drive all of the population health metrics, all of our quality metrics that we track, making sure that they're getting all of their screening, getting all of their chronic diseases as well controlled as possible. And ultimately, that's what leads to lower inpatient stays, lower ER and urgent care visits to decrease that cost. So we're in a great position working directly with employers to truly improve quality of care and reduce costs.
Yeah, Sarah, how does crossover think about it? I know your part of your model is digital interactions, asynchronous texting, things like that. How do you balance those different types of modalities and kind of strike that balance of worthwhile utilization?
Yeah, great question. And I agree a lot with what John said. It also, to tie the string back, it does come down to data and measurement, right? So for all of our services, we have what we call a clinical operating system. So these are dashboards that our providers can use to see how they compare to other providers within our book of business and how they're comparing against benchmark data. So if we have a group of physical therapists that have patients with these conditions, then we can see, are they getting them better at the same rate or at a faster rate than those in the community or those within their rest of their book of business. So when we look at utilization, we start at the top. How busy are they, right? If it turns out they're really busy to the point where we might be thinking about adding staff, then the very next thing that our practice managers and our clinician leaders will do is go to the quality dashboard. Are they treating people appropriately? Are they getting the right number of visits? Most importantly, are they driving the outcomes? Because if the visits are driving progress, that's one thing. But if they're, double or triple what other providers in our company are doing, then that would like flag a chart review and things like that. So we want to make sure they're providing good quality care. And then we have referral pathways. So we can measure, the percentage of people that come into physical therapy. What of those actually convert to primary care? And we do that with every single modality. And that allows us to pull some levers. So we tried something where our physical therapists started taking blood pressure, right? They're in the integrated center. They started taking blood pressure at the start of the visit. And then for anything that was even remotely close to questionable, they would send that over to the primary care team and they would be able to establish care. So I think there's, we all work in this integrated environment. And so we should be doing things that try to connect those groups together to really, as John said, keep people out of the community. And the crux of that is empowering the providers with information. As real time as you can get. It does get tricky to be really, sometimes there's a week, month delay, but for the most part, they should be able to open their panels and they should be able to see how they're doing. And then, give them some extra information, like what are their referral rates? How sick are their patients? What patients in their population should really be going to primary care that have no designated primary care provider? And so the more you can empower your providers and the health center staff, then the more within the context of that center, they can just drive to the good quality care.
There's obviously a lot of complexity in trying to, take the data that you have accessible to you, and then there's different stakeholders within the chain. And I often refer to, the relationship between the employer and the vendor partner in, essentially identifying actionable opportunities and then making sure that we're actually following through. So a lot of the discussion as I listen to it is thinking kind of from the perspective of within the vendor kind of framework and within the clinic operations and the different teams that are available to support the health center. But how do you see the employer stakeholder fitting into this process? At what point do these opportunities get flagged and raised to the employer sponsor? Because often they need to support actions that are needed. So, how do you think about that? How do you prioritize things to the point that it needs to be transparently shared with the employer partner? And I'll keep it with you, Sarah, since we're.
Yeah. So Katie made a good point earlier that there's many different cohorts, but kind of at that top level, there's like the people who haven't engaged and the people who have. And I think largely speaking, the people who have engaged is the responsibility of the care team and the medical group to make sure they're doing that well. And then reporting out to the client monthly, quarterly, annual business reviews to make sure that the client understands that we are meeting those expectations. And if we're not, what we're going to do. So typically, if we needed to get an employer involved in the member cohort, so people who are actively using care, it's because we have a bit of a problem that we want to maybe address with them. Like, for example, if we have a really, really, really high no-show late cancellation rate to the point where it's affecting, our ability to get new patients in the door, that might be an area of partnership. How do we want to we have some suggestions, but we want to make sure it's in line with the culture of that group. If we have like frequent flyers to the extent that that's not really providing value. So sometimes we see that when employers make everything $0. I mean, we love that on one end, but on the other end, we have to make sure that we're managing that and we don't have someone, 54 visits for mental health when there's a huge demand on the other end just to get people in. And so we can talk about different ways that we would suggest managing that, but wanting to make sure it's in line with the employer. And then I think on the other end, so the non-members, this is probably by far the most complicated and where we need the most partnership. And it comes down to really just making sure we know the cohorts and we know what we're going to drive to. So if we have a really big gap for new users, oh, sorry, I thought I heard someone chiming in. If we have a pretty big gap for new users, then we're going to cohort those, and we're going to like first look all of our standards for this type of client, right? If it's mostly deskless workers or warehouse workers, we have sort of a profile of things that we do that can reach them. Are we doing that? Are we not doing that? That's just a place to start, right? This is what we know works. What of these work for you and don't work? If it turns out that only a small percentage of them do, that's when we get creative, and that's when the partnership really starts. We try to bring as much knowledge, information, make it as easy as humanly possible. We'll write the emails, we'll co-brand, we'll do all the things, right? But we do need those employers in that scenario to really dig deep and figure out what might work with their rules and within their population. And then it's the scientific method, right? We're going to set hypotheses. We're going to say, we're going to do these 4 things. We believe it will drive, 10% extra. If it doesn't, why? And that's what you talk about every single month, right? If you're really focused on driving engagement, you need to be looking at your incremental progress, what's working, what's not, and iterating quickly. Otherwise, you're going to get to the end of the year before you know it with a big mountain to overcome.
I'm sensing this is not turnkey. This is something that needs active management.
Yeah.
Leah, from premises perspective, or your individual perspective, as you're looking at a client's non-user group, the people who have never walked through the health center, maybe you don't have any data on them even. How do you diagnose why they're not users, like that they've chosen never to walk through the doors?
Yeah, I think that it is really important that there is a good understanding of starting with that good foundation. You've got to have, it's got to be convenient. It's got to be accessible. You have to have the right staffing model. It's got to have easy digital tools that work. You have to be able to lower the financial barriers. There has to be executive level support. And there has to be the ability to have consistent and ongoing messaging for that awareness, and the ability to perform proactive outreach. I think when you start with that type of foundation, then you have the ability to be, really successful. So before you start really trying to over engineer some type of engagement strategy, I think the employer and the health center partner, direct health center partner, and the consultant need to look at the basic components to see that they are established and that they are working well. Because oftentimes we do find why people just aren't using is because they don't know about it. And we haven't reduced those types of financial barriers that make it easy for them to come in, whether they're an employee or a dependent.
To restate that a little bit, it sounds like essentially going through your checklist and of best practices and kind of identifying where there might be gaps for a specific that specific employer. Katie, how would you approach that? Does that align with how you think about things? You think about things any differently?
Yeah, I think the basics or the foundation, Leah, are so important. 2 pieces of that that you touched on. One is the leadership support. So, if we're talking about a manufacturing population and we've got lower engagement, we like to get to the line level leadership, right? And so maybe we'll do a luncheon with those individuals to make sure, one, they understand, promote, and help encourage their team to use the health center. So trying to get to that middle management layer, when the CEO and CHRO are big fans, that always helps. But I find that you got to get to that mid-level management. And the other piece of this, and maybe we were just kind of leaving this to be a big topic, David, I don't know, but incentives, right? So are there Is there an incentive design or an incentive program that really encourages that utilization at the health center? Whether that be anywhere from, a reduction in your premiums, or it's a deposit in the HSA, or it's a gift card to, a local Target or Walmart, whatever might be kind of the driving piece here to get that behavior. Incentives play such an important part of it. And so when we start the conversation with the employer, we always want to understand, like, hey, what's your wellness kind of programming today? And if you don't have any, here's a template. If you have something, how can we plug into it? But alignment of those incentives is critical piece of this puzzle to get users in the door and keep them engaged.
Yeah.
Hey,
Completely.
Katie, if I can just add
Yeah.
on to that, if you don't mind, David, there is a great example of that, and I'm glad that you brought that up, Katie. We've got a Midwest employer that was really focused on engaging their full eligible population. And it's actually a younger population, so they don't seek healthcare often, but they are very costly when they do. And so this was a brand new wellness center, and their goals were really to get buy-in and increase awareness. And so Premise worked with the employer and their consultant as well to really understand what the employer had budgeted from an incentives perspective. And so there was an incentive that they had typically given for anyone that completed an annual physical, and they only had about 28 to 30% of their 13,000 employee population achieve that. And so it wasn't very high. And so they decided to take those dollars, those $350, and they offered them to anyone that could just download the app and create a portal account. And from that initiative, 90% of that 13,000 completed that that initiative, and it created such strong utilization right out of the gate. And its continued momentum. Shortly after that, we had to hire additional primary care, behavioral health, care managers. And we've continued to maintain a really healthy volume and grow that utilization. And that was from one really great incentive opportunity.
Yeah. Plan design and incentives are critical to any engagement strategy for sure. Those are great results from that case example. Dr. Bussell, how do you think about it at QuadMed from as you either launch a new health center or kind of reevaluate an existing health center? And then broadly, and this would go to the group as well. What are the trends that you're seeing in terms of plan design and incentives, kind of, with your history in the industry? John,
Yeah, I always say people, it's basic behavioral economics. So people respond to incentives and barriers. And so no amount of marketing is going to overcome a poor benefit plan design. And so that's where we all go back and look at the data, try and figure out what the right design is going to be for that population. And it is a little bit trial and error sometimes, depending on what the population is. And that's something that you have to work on, where, it's great to be, some of these strategies can be month to month. Sometimes benefit plan design is year to year. And so this is a long-term partnership that we just look at year over year. How can we continue to tweak it and make some small changes that will engage more and more of that population? So obviously things like, $0 copays coming in to the clinic, a little bit higher premiums to use the outside. They're really pretty basic things that you just have to move those levers. And the more we move those levers and drive an understanding of the value of the health centers, can really make a big impact in the long run. So I think in the grand scheme of things, as long as we are trying to reduce costs to use our health centers, trying to increase the cost to use the community, and then making people very aware of that, because there are still, 15 to 20% of any population that just don't pay attention to their premiums, don't pay attention, they're on the plan, but they're not really aware of that. That's where that partnership for me is really important, to have the CEO and the CHRO involved with the health centers. Those are the situations where we feel that we have the most success, because they can help drive that benefit plan design and get some of that engagement from the completely unengaged population in their groups.
Other thoughts on trends in plan design and incentives?
I'll just add to that. I've got a few customers that have played around with I would call it like a narrow network plan, where if you're inside the health center, there's absolutely zero cost in the plan. And, John, to your point, once you move outside the health center, right, there's kind of layers or components to engaging in the community. And if the health center is doing a really good job, helping to manage that panel or that population and referring them appropriately, they're paying attention to their plan design, right, and helping them get to the right, point of care, specialty care, or testing and diagnostic care that aligns with their plan to help save. So I think I would like to hope that we can continue to see a trend around that. That type of tight plan that helps get engagement in the health center. The other piece that I've seen a little bit too is around, I wouldn't call it like penalties. I guess that's sort of that plan design, but like, how do you penalize, right? And make sure that the individual who is choosing not to use the health center or, follow the plan design certainly, feels it, right? Cash is king. And so if I'm all of a sudden paying more for something and I land on, one of our data mining exercises, and the health center team that's making that outreach to me can help me understand kind of, you've been paying more out of pocket than you should. There's a lower cost alternative, right? How do we take advantage of maybe a poorly designed plan as well to help drive engagement in the health center?
No, those are great examples.
I
Go
think
ahead, Lynn.
also another thing is vendor referrals back to the health center. So as other vendors are within that benefit design that the employer uses, that there is that process worked out where those vendors, if there's a need for primary care or any services that the vendor at the health center is providing, that they are the priority to refer back to.
Yeah, Leah, that's exactly what I was going to say, is really super important to get that ecosystem integration, right? We have a lot of navigators that we partner with, and making sure that as people come into that front door, that, they're kind of saying, Katie, the comments that you were saying, right? Hey, looks like you've been going into the community. That's 3 times more expensive than if you went to the, right? So making sure they're funneling people back in. And then to the extent to that, the on-site employers can actually work with other partners as well. So we've seen a lot of success partnering with EAP and saying, hey, we'll do some heroics magic on the back end, but your people can come to us, get the EAP credit. We'll make sure you know exactly who they are. They get those first 3 visits for free, and then their high deductible health plan or something kicks in. I mean, we've studied that. And I mean, the people who come in, they get established, they get those 3 visits, they're actually more likely to continue through the treatment, likely because they now trust their provider and they have some more information about that this is really going to work for them. We do see drop-offs at the end of that EAP as well, but it just shows, I mean, cost is a barrier for many. And so to the extent you can be working with those partnerships, then that really just starts to drive value across that entire benefits ecosystem, not just through one vendor.
I do have a question that came in from Joe. And Joe, there's a long question, so I might actually encourage you to come off mute and maybe give a little color to what you're asking.
Yeah, of course. Thank you guys. This is great so far. Yeah, I guess we're just looking for maybe average trends in utilization over the first couple of years. Obviously, we want to see a spike upon open and then maintain that spike, if not grow, right, to those who haven't heard about it. And as word of mouth takes off and we come up with creative comms events and incentives to come down. But eventually, right, the employer is going to maybe use public facing data to say, hey, why is my subset of 1,200 employees coming down 10%, 15% more frequently than the public, right? Because that kind of value of investment of getting them back to their desk is sort of our niche. So I was just wondering if some of the larger organizations maybe dealt with this conversation in the past, and maybe if there's data on, utilization rate eventually capping out or eventually shrinking over X amount of years.
Who wants to tackle that one?
They're all smiling.
I'm not sure I actually totally get the question. So is it and I think there's multiple in here. I think I heard you say like, how do you consistently grow utilization over time? That might have been one question. Is that right? Did I get that?
Well, yes, yeah. And obviously in the first 2, 3 years, we're seeing spikes, as people learn about it. But I'm saying as an employer,
Mhm.
right, they start to see, okay, my 1,200 employees are coming in much more frequently than a subset of 1,200 people in the public.
Mhm.
Has anyone had dealt with those kind of conversations in some of these larger institutions?
Yeah, I can take a stab at that. So I'm going to break your question into two, which is that sort of sustained utilization growth, and then what happens if your 1,200 people are using it away at a much higher rate than that of the community? How would you diagnose that? So I think the first one is you've got to kind of look at your churn rate. So if you have a employee base that doesn't have a lot of tenure, right? We have some employers who everyone's worked there for 25 years. We have some where it's kind of like they have a 30 or 40% churn rate just by the nature of their business. So that's going to be a pretty big influencer, right? To whether or not you have an opportunity to continue to grow engagement or if it's going to cap out, or kind of like start to taper off. The more as an employer, the more that you can get in front of every new employee, the more effective you're going to be at consistently driving utilization over time. So a sort of a simple tactic that can be used is like new hire orientation. If your on-site health center, information about it is included in every new hire orientation, that's like touch point number one. Everyone new comes in, they know about it. That gives the on-site vendors an opportunity to follow up with relevant communications that will drive them forward. So new people have to know about it, right? And if consistently new people know about it, then you tend to, it's just one tactic, but it can be a way to maintain utilization even as you lose people. And then if you see overutilization, this is where you really have to push on your on-site partner to be able to tell you why. And that all comes down, in my opinion, to clinical analysis, right? So you have benchmark data that, these, for physical medicine, they should be getting seen in 6 visits or less, or whatever it is, right? Then you can compare yourself to the community. And if your physical therapy team is seeing them in 14 visits consistently across, on average, then you would want to say like, why? Are they sicker? Is that clinically relevant? Right? You sort of can start to dig in there once you figure out, you have to put your finger on the problem. Is it an ancillary service? Is it primary care? Is it the kind of clinic that's like, oh, you can schedule an appointment for your labs and you can schedule an appointment to review your consult results, right? Are they driving visits or not? I think that really comes down to a clinical assessment to make sure they're treating people appropriately.
Great. Yeah, thank you, Sarah. Yeah, I did not think of the turnover rate in these larger organizations too. So thanks.
Yeah.
Yeah, and I think from a clinical perspective, it's, we don't incentivize our providers to see patients more often, and that's a big difference from the community. So, we may, if you compare just a random 1,200 people to 1,200 people that are being seen in the clinics, they're probably going to be seen more often because we tend to take care of higher risk populations. they tend to come to us because they have that extended visit time. We have, the model of care that we provide.
Right.
And so it's not an apples to apples comparison. So we look at risk scores, try to drive that conversation to say, this population should be seeing, this type of a cadence, and these are the quality metrics that are demonstrated because we're managing them as well as we are. There's always going to be a subset of a population, especially in a younger, healthier workforce, that doesn't go to the doctor ever, and they're not going to, and they're not going to come see your health center because when I was a guy in my 20s, I never went to the doctor. Even when I ruptured my hamstring, I limped for 6 months instead of going to the doctor. So I think that's just the reality of the population that we're taking care of, and we just need to have the data to be able to demonstrate that story.
Great. Thank you, John.
Thanks for the question, Joe. We're close to time. Other questions from the audience? Feel free to submit via chat or come off mute. See one from Carmen. Questions about the clinic acting as a gatekeeper for referrals.
Yeah, Carmen, that's exactly the way the plan's designed, right? So if we're serving as the primary care, we're responsible for managing that referral. And so here at Marathon, we have a program that's powered by data from Garner, and we look at cost and quality, and it helps us make better recommendations to a patient. We give them a series of choices. So if they need to be referred to their mammogram, we work with them to identify where they want to go. We evaluate against the Garner data. We make the recommendation, and then we help the patient by doing the scheduling and any pre-cert or pre-D that's needed inside the health plan. So it's a full closed loop type of referral process. And then what actually happens is, because this has happened to me, if I cancel that appointment and don't complete that service within a certain amount of time, I'm getting that customized outreach from our clinician reminding me the importance to complete that annual screening, and if I need help getting that scheduled. So that's exactly the intent of the design. Have the team better control what's needed inside the four walls, and better refer what's needed outside the four walls, and making sure it gets completed.
And then I think also part of that question was, the second part of it was focusing on use of incentives for compliance with that referral. Leah, Sarah, would you like to tackle that?
Yeah, we have a program where that we work with our employers, and we, similar to Katie, we use a company called Healthcare Blue Book, and we can set up incentives if they choose that specialist or facility that they need to be referred to. That is what we call green on green from a cost and quality perspective. Then there are incentives that they will receive. They can receive a debit card with $150 on there, or it can also be incentivized for additional dollars that are within their member engagement wellness platform, like a Sonic Boom or a Virgin Pulse or something like that from an incentive perspective.
Question. Other questions from the audience? Just got a couple minutes left. And maybe just in closing, I'll go around with the panel, just final thoughts on the most important things to prioritize in terms of maximizing utilization for a health center, or alternatively mistakes to avoid. I'll start with you, Dr. Bussell.
I think just to throw out a couple other things, when we're trying to optimize utilization. We really want to be targeted in our approach. So one of the things that we've really harnessed is Epic campaigns. Campaigns is a module within Epic that targets people based on their missing quality metrics and missing screenings, or depending on a lot of different factors, and we can set it, forget it, and have a really good, robust population health tool to get people in the clinic and to get their screening measures done. So utilizing technology to its fullest, I think, is really an important feature. I think all of us have different technological capabilities, and make sure that we're addressing our needs of our patient and member population with that technology is really important.
That's a good point. Katie?
Yeah, you had a prep question for us around getting spouses and dependents engaged as well, and so maybe I'll just touch on that. We've seen open houses be successful, or like a family style picnic, or if the employer's doing something for their employees and their families, how can we be a component of that? So, I think we all know spouses tend to drive a high percentage of claims cost. And so it's just as important to have a plan to engage the family members if they're also eligible to use the health center. So don't forget that piece as well.
Thanks for clarifying that one. And Sarah?
Yeah, I would say there's no silver bullet. There is not one thing that you can do and they will all come, right? But we have looked at the data. So we looked at every single client from year 1 to year 2, mapped out their penetration rates, overlaid all the tactics, looking for that silver bullet. Like, is there one thing that worked that drive the most penetration? And the thing that came out as by far the highest, so driving 2 and 3 times the penetration rate from day 1 all the way to month 24, was clients who could introduce Crossover as their trusted partner and then allow us to follow up. So you have to find a way. It sounds simple, but it can actually be quite difficult for really large populations. You have to find a way to introduce that your vendor that you chose for on-site health vendor is the trusted vendor you chose, and then allow them to follow up. It takes 3, 4, 5 times as many touch points for us to get to a person if they don't know who we are. It's kind of like cold calling. We get so much spam. There's so much noise everywhere. It's really hard to get through to someone. So you got to lower that trust barrier, right? Let them know, hey, this is our trusted partner. Then we can be way more effective. And then to that point, I'm going to kind of go, Katie, off what you said. Employee is an advocate. They've got to love the experience. If they love the experience, you give them as many ways as possible to share that. Invite a colleague, invite a spouse, invite a dependent. It's got to be nice and easy, right? So we think of the employee as an advocate and the employee as a way to get into the household. So give them a really great all-star experience with tools to easily bring their colleagues and their family in. And those 2 things alone, if you focus on that, you probably should get somewhere.
Great points. And Leah, we've got about a minute left.
Yeah, I would say all of those are really great, and agree with Sarah. There isn't that silver bullet, but there are a lot of things that can really help drive utilization. And I would say data is critical, and really understanding that. We have found that, as I was, preparing and thinking about this conversation and looking through success stories with our clients and case studies, they all had very similar things in place. They really focused on primary care. They were able to allow the providers have access to the data that they needed, and they have the tools and accessibility to meet the members where they need to be met, whether they're an employee or a dependent, and they were consistently allowing us to communicate to the members, whether engaged or not engaged.
Great. Well, we are at time. I want to thank our panelists, Leah, Sarah, Katie, John. Thank you so much for participating. Thanks everyone for attending. Appreciate your engagement, and everybody have a good day.
Thank you.